Good afternoon. So we'll start today's topic, that is lithium toxicity. Lithium toxicity is something which you will see in emergency department and may get confused with other similar conditions which can occur in other medical illnesses. So just a brief introduction about lithium. We majorly use lithium in a carbonate form for a mood stabilizer. It is used for the treatment of bipolar disorder, particularly for managing mania and preventing recurrence of mood episodes. There are other indications as well, which we'll see in the later slides. So the exact mechanism of lithium is not really understood, but there are still many neurotransmitter pathway and intracellular signaling which has been shown associated with mechanism of action. So in second messenger system, lithium inhibits enzymes like inositol monophosphatase, which affects the phosphodiol inositol cycle and regulates signal transduction in neurons. Next, there is also a neuroprotective effect of lithium is being seen, wherein it affects this glycogen synthesis kinase, which is involved in neuroplasticity and cell survival. Similarly, BDNF factor का भी association has been seen, which is showed promotes neuronal growth, survival, and synaptic plasticity. There are other theories which says कि serotonin, dopamine action is also being affected by lithium. Talking about pharmacokinetic, it is quickly absorbed and reaches the peak serum level within 1 to 1.5 hours for standard form, and if you are using an ER or extended release form, 4 to 4.5 hours. Mainly excreted by kidney, and there is some loss which can be seen in sweat and feces. It can also be transferred from breast milk as well. The elimination half-life is 18 to 24 hours. Uh, Next thing is lithium toxicity is what? It occurs when serum level exceeds the therapeutic range due to overdose, drug interaction, or impaired renal clearance. And it is an emergency situation which requires immediate medical attention due to its life-threatening potential. So what are the indication wherein we give lithium? Bipolar affective disorder, major depressive disorder, schizoaffective, schizophrenia, in aggression. It has also been shown to be effective in suicide prevention, agranulocytosis, or cluster headaches. So moving on to what are the recommended serum lithium concentration. When we talk about acute treatment during the acute manic episode, the target serum concentration is 0.8 to 1 millimole per liter. For maintenance therapy, target serum is 0.6 to 0.8, and for augmentation in unipolar depression, we also, as we have seen in indication part, in major depression also lithium can be given. Target concentration is again 0.6 to 0.8 millimole per liter. Now, when does the toxicity level is seen? When the serum lithium level is more than 1.5 millimole per liter. Mild is 1.5 to 2 milliequivalent per liter, moderate is 2 to 2.5, and severe is more than 2.5. So there are certain clinical guidelines which you should keep in mind when you're starting the patient on lithium. A baseline blood investigation including renal profile, thyroid and cardiac function test should be done. ECG should be done, and along with baseline weight and BMI monitoring is also advised. Etiology and risk factor for lithium toxicity. So what are the causes and other risk factor which can give rise to lithium toxicity? First of all, dehydration like diarrhea, vomiting, excessive sweating, fever or inadequate fluid intake. It can raise the serum lithium level. Next, as we know, lithium is cleared from the kidney. So renal impairment like CKD, AKD, age-related decline in renal function can also result in increase in serum lithium level. Again, hyponatremia due to excessive sweating or poor dietary intake or the use of diuretics is also one of the factor which can cause lithium toxicity. As the age advances, the kidney functions are said to be deteriorated. So the multiple drug interaction can be seen in this case as well. In certain cases of gastroenteritis, severe infection or other condition where significant fluid loss is there or any renal impairment occurs, there also the serum lithium level can rise. Rapid dose titration, please keep it in mind. Lithium without appropriate monitoring or including the daily, exceeding the recommended dose can cause lithium toxicity. Again, there are certain drugs which can cause interaction with lithium and raise its serum lithium level like NSAIDs, in diuretics, thiazide diuretics. ACE inhibitors, ARBs, SSRIs, and certain antibiotics like metronidazoles are also found to be notorious in increasing the serum lithium level. So if we talk about clinical presentation before the lithium toxicity, there are certain side effects which are dose related for lithium, which can be managed symptomatically as well. So like diarrhea, abdominal discomfort, nausea, tremor. In intermediate side effect, you can see again it might lead to insipidus, diabetes insipidus, ataxia. Again, diarrhea and nausea can be seen in both the cases. And there are certain dermatological side effects like acne and alopecia has also been seen associated with renal toxin, lithium adverse effect. So when we move on to toxicity, when there is mild to moderate lithium toxicity, that is when the serum lithium level is 1.5 to 2 milliequivalent per liter. In GI side effect, you might see vomiting, abdominal pain, anorexia, diarrhea, and nausea. Whereas in neurological side effect, ataxia, coarse tremor, confusion, drowsiness, muscle weakness, and slurred speech can be seen. When moving on to moderate to severe, that is lithium level is 2 to 2.5 milliequivalent per liter. You can have persistent nausea and vomiting, whereas a neurological side effect, muscle twitching, clonic movement of the limbs, seizure, disorientation, coma can occur. Arrhythmias and conduction abnormalities are also seen. That is why baseline ECG is always advised when we start lithium. And in severe cases wherein it is more than 2.5 milliequivalent, generalized convulsion, oliguria, renal failure, coma, and death ultimately. So these are just a table. This is just a table to show the major side effects, major ill effects of lithium toxicity. So how will you diagnose if the patient has lithium toxicity or not? Other than the clinical presentation, you will correlate it with serum lithium level. Serum lithium level is main indicator for diagnosis. Additional electrolyte like sodium and potassium disbalance, thyroid function test, blood urea and creatinine, ECG to detect arrhythmias, and urine analysis for kidney function. Now the differential diagnosis, there might be certain cases which might look like lithium toxicity, like alcohol intoxication, wherein slurred speech, dizziness can be seen, drug overdose, especially benzodiazepine and opioids, electrolyte imbalance, especially hyponatremia, uremia, renal failure, and certain neurological conditions like stroke and encephalopathy can look like or manifest like lithium toxicity. So management part, you will discontinue the medication immediately. Please keep in mind whenever the patient is coming to emergency, ABC is your rule. Check for airway, breathing and circulation of the patient. Give symptomatic treatment whenever required, oxygen inhalation, IV fluids. Gastric lavage, if overdose is recent, you can repeat it as well. Obtain an urgent serum lithium level to confirm toxicity. Administer IV saline. Avoid hypotonic solutions like D5, which can exacerbate hyponatremia. Correct the electrolyte balance, especially if hyponatremia is seen. Hemodialysis may be required if the intoxication level are higher, that is more than 3 millimole per liter. It might be seen that lithium level can increase after initial dialysis due to rebound effect of lithium. So multiple sessions of dialysis can be required. Clinical symptom may improve slower than serum levels due to slow CNS clearance. Okay. So to conclude, lithium toxicity is a medical emergency requiring prompt diagnosis and treatment. Ensure that patients are aware of symptoms and drug interaction. Whenever you're prescribing lithium, tell people about these are the following side effects, this can happen, and tell them about certain drug interaction. Inquire their medical history, their psychiatric history as well. Baseline lithium workup, as I already told you. Serum lithium concentration is the best indicator. In fact, when you start lithium, after 5 to 7 days, serum lithium monitoring should be done. What is the concentration of the drug? Whenever you change the drug, whether you increase or decrease the drug, again the serum lithium monitoring after 5 to 7 days of changing the dosage of the drug should be done. And it requires immediate medical attention. These are the references, and thank you.